What do you see?
3 frontal chest radiographs. There's a pulmonary nodule in each one. Here, here, and here. They're all very well demarcated and look quite similar to each other.
2 of these patients are alive today. The third one died at the age of 15. Which one died?
I'd want a CT to better characterize the nodules.
These films are from the 70s, before CT was widely available in this country. If you had to choose, which one would you pick?
Call from MR Tech. Accept?
Yes.
Oh, hi, Dr. Culham. Sorry if we're interrupting anything. We're ready for you in MRI.
I'll be right there. Let me know when you figure it out. Oh, and I'll see you on call this weekend.
Wait, Dr. Culham.
Code Brown, ER waiting room. Code Brown, ER waiting room.
So, several weeks of left flank pain, hematuria, CVA tenderness, and blood on the urine dipstick. What do you think is going on?
Maybe a kidney stone?
Maybe. What else? Would you please print me off an imaging rec for Smith?
Infection, like pyelonephritis?
Okay, keep going.
Urinary obstruction?
Caused by...
Uh,
Oh, thanks.
kidney stones. No, but I already said that.
Oncology online too.
Prostate cancer.
Clara, I know I said to broaden the differential diagnosis, but try to avoid impossible diagnoses.
Right.
Here, let's get her a CT KUB. And why don't you go down to radiology and review the images once they're done?
Oh, sure. Review the images with who?
With the radiologist. Might be good for you to see them in person.
Right. Okay, sure. Thanks, Dr. Cheung. Hello?
I thought I heard someone. How can I help you?
Oh,
Are you okay?
yeah. I'm Clara, an MSI3 from Emerge. I was hoping to look at some scans.
Oh, for sure. Come on in. I'm Melanie, one of the radiology residents. Did the lights in the hallway burn out? It's not usually so dark. Let me turn up the lights in here. There. Perfect. So following the ureters down, there are no stones bilaterally. stones would show up really bright if they were calcified, kind of like bone. And we often also see hydronephrosis and hydroureter if the stones are obstructive, and there's none of that here.
So, no stones.
No stones. But maybe cancer.
Maybe cancer. Wait, what?
It's this soft tissue lump here. It looks pretty suspicious. Do you think you could order a CT renal mass protocol? It doesn't have to be done tonight.
Oh, sure. How did you do that?
What do you mean?
How could you tell that gray lump apart from all the others?
Oh, well, I mean, it was lucky that I could see this one. CTKBs are usually only good for stones. You need contrast to look for cancer, which is part of the renal mass protocol.
Right.
But to answer your question, I mean, this lump looks suspicious because, well, its Hounsfield units show that it's denser than simple fluid, and just by looking at it, it doesn't look like the others.
Oh, that's cool. That you can see that, I mean, since they all look the same to me.
Sorry, that probably wasn't very helpful. I really think radiology is like a high-stakes spot the difference, but the normal's in your head, and it's based off of all the normals that you've seen before.
Oh, okay. I never thought of it that way before. Well, thanks for going over the scan with me. I should probably get going. Oh no. Oh. Sorry. It's okay. Whoa. Old plain films?
Yeah,
Aren't these from like 100 years ago?
50 years ago. And don't let Dr. Culham hear you say that.
Who's Dr. Culham?
He's our most senior radiologist, and one of the reasons I wanted to become a radiologist in the first place. But right now, I'm just trying to figure out what he sees on these x-rays. What do you see?
Oh, well, going from an ABCDE approach, I actually can't remember what that stands for. So going from an outside to in approach, starting with the bones and soft tissue.
That's okay, just focus on the abnormality.
Well, there's a giant lung nodule. In all three of these, actually.
Turns out, 2 of these patients live, and one of them dies. And I'm supposed to figure out which one.
And you can tell just by looking at the x-rays.
According to Dr. Culham, yeah. There just has to be something I'm missing, though. Anyway, there are a bunch of new scans from Emerge to protocol. I should get back to work.
Oh, yeah, for sure. Thanks for showing me all this cool stuff.
No problem. Good luck with clerkship.
Thank you.
See you around.
Bye. All right, Mr. Liu, take another deep breath for me.
No more deep breaths. See, this is what I've been coughing up over the past week.
Oh, yeah, wow. That must be very, difficult for you.
So, what do you think it is, Doc? Is it cancer?
This looks more like an infection, but I'll have to check with my staff. Oh, no smoking, right?
Oh, no, never.
So, tell me the story. And try to be more concise this time.
Right. So Mr. Liu is a previously healthy 52-year-old man presenting with a 3-week history of intermittent fever and cough, now experiencing 1 week of purulent sputum and worsening shortness of breath.
Much better. Anything else pertinent in history?
No medications, just taking ibuprofen as needed. No allergies, no recreational drugs. Oh, he also has a 5-year-old at home who was recently sick with a cold.
Okay, so there has been a sick contact. And what about the physical exam?
I think there was decreased air entry in the right lower lung with some crackles and wheezes. Oxygen saturation was 98% on 3 liters. His last temperature was 39 degrees.
Okay, so what do you think this is?
Secondary bacterial pneumonia following a recent viral infection.
All right, what else?
Oh, Maybe a viral pneumonia? Well, he didn't have any chest pain, so probably not a heart attack.
So you were right. It is a lobar pneumonia in the right lower lobe. But I do think you need to work on broadening your differential diagnosis and having a more structured approach. Internal medicine will want to see that from you next week. But good job on your histories and physical examinations. Keep on reading and you'll do just fine.
Will do. Thanks, Dr. Cheung.
Hey. Hello?
Oh, sorry, can I help you? Oh, Sarkin, I thought you were from surgery.
Did I scare you? I'm on IR right now. What are you still doing here? It's past 6.
I know, I'm just trying to get more plain film experience.
Ah. Resin torture devices. Did Dr. Culham put you up to this?
Yeah, and I'm on call with him tomorrow night too.
Do you want me to take a look? Maybe we can figure it out together.
Isn't that cheating?
Says who?
Says me.
Ah, fair enough.
Hey, Sargon, what made you choose radiology?
Oh, lots of things. The diagnostics, the problem solving. You know, all of the most interesting cases go through us. And we get to do so many cool procedures.
Oh, are you gonna do interventional?
Maybe. I do like putting tubes through other tubes, but we do so many procedures in general radiology anyways. What about you? Why radiology?
Well, I want to be able to figure out a patient's story just by looking at a single x-ray.
I'm gonna steal that one for my interviews.
Wow!
Anyways, you should get home soon, and good luck on call tomorrow.
Thanks. See you. Oh, hey!
Hey, are you also here to study?
Yeah, I figured I'd get some review in before my first independent call shift tonight.
Wow, that sounds kind of scary. Are you all on your own?
More or less. I mean, we can call staff if we need to, but we try our best not to wake them up. What are you up to?
Broadening my differential diagnoses.
Well, that sounds even scarier.
What do you mean?
It's the hardest part of medicine.
Wait, really?
Well, yeah, you need to know about a lot of diagnoses, but every body part and body system has so many different things that can go wrong with them.
Yeah.
And out of all of those things that can go wrong, you need to figure out what's most likely for your specific patient.
Yeah.
But patients can sometimes be really poor historians or completely unconscious, and then you only have objective findings to rely on instead.
Yeah.
But even objective findings can contradict each other. Sometimes everything can point to one diagnosis, but then it turns out to be something completely different because diseases don't read the textbooks.
Yeah.
And that's why I'm in radiology, so that I can just play spot the difference all day instead.
Yeah. Wait, what?
I'm just kidding. Having a good differential is actually one of the most important things in radiology. After all, we need to figure out what's causing those abnormalities we see, and whether there's something people actually need to worry about.
And here I thought the CT donut of truth would give me all the answers.
The donut gives you the images, but a good differential gives them meaning.
Guess I should get back to that.
Don't worry, it'll only get better.
I sure hope so.
All right, I'm gonna head out for my call shift. Are you okay?
I don't know. I included prostate cancer in a differential for a cis woman yesterday, and at this rate I'll probably do it again.
You know, I find exercise can help with long study sessions. I've heard it can help with retention too.
Studying and exercise?
I never thought of that, actually. That's a really good idea.
Wait, what are you?
I'm gonna go do that right now.
Wait, Clara, I didn't mean at the
Thanks, Melanie.
same time. All right, let's do this.
Pneumonia. Pneumothorax. Pulmonary embolism.
Musculoskeletal pain.
Consistent with acute cholecystitis period, general surgery consultation is recommended period. The celiac axis and SMA are supplied by the false lumen. So, yeah, what are you guys planning to do?
Yeah, I'm gonna stabilize him with beta blockers now, and then we gotta get ICU and vascular to help out.
Makes sense.
Pancreatitis. Diverticulitis. Appendicitis.
So gynecology consultation is recommended. Of course, no problem. Bye. Whew.
Asthma. COPD exacerbation. Lung cancer.
And then lots of gray white differentiation loss, mostly in the right MCA territory. So I guess that explains the symptoms.
Got it. Thank you so much.
Yeah, no problem.
Epidural hematoma. Meningitis. Migraine. Sinusitis. Subarachnoid hemorrhage.
Good morning, Dr. Culham.
Good morning. Well done on your first call shift. I was just having a look at this scan that you did last night.
Oh, yeah, this one. What did you think?
So you reported this scan as pneumonia.
Oh, sorry. I feel like I should have included aspiration in the differential too.
Not that. Go to the soft tissue axials and scroll down to the bottom of the stack. What do you see?
There's an adrenal nodule. I'm sorry, I must have missed it when the work list was piling up last night.
That's all right. These findings aren't critical to report overnight. That lipid-rich adrenal nodule doesn't even need follow-up. The point is, I know you didn't look.
I'll be more careful next time.
It happens. The first and last images in a stack are where people tend to miss things. We just have to give them a little extra attention.
Oh, Dr. Culham, about those pulmonary nodules on the plain films you gave me.
Mm-hmm. Have you figured it out?
Not yet, but,
Let me know when you have.
Melanie!
Oh, hey, Clara. What are you doing here?
Studying. Thanks for the tip the other day. It really helped for my differentials. Donut of truth for you.
Oh, thanks.
No problem. I'm studying joint pain next. See you around.
Bye.
Next is Nelson. New diagnosis of CHF, still on some oxygen, pending an echo. His potassium is a bit low last night, so we got some replacement. And then last is Liu, guy admitted with a pretty bad pneumonia. He did well over the weekend though. He's been stepped down to oral antibiotics and can probably go home today. He's still on emerge.
I think I saw him on emerge last week.
Great. You can round on him today then and prep his discharge summary. And that's the list. Pretty short one today. So students, you can start with 2 patients. Junior residents, you can take 5.
And med students, remember, you're on internal medicine now. Try to be comprehensive and thorough.
All right, done seeing Stuart.
Excuse me, are you seeing Mr. Liu?
Oh yeah, what's wrong?
He's having new chest pain and worsening shortness of breath.
When did this start?
Just this morning. No problems overnight. He just got stepped down to oral antibiotics yesterday.
Mr. Liu, what's wrong?
I can't breathe. Chest hurts.
Well, tell me more. I heard it started this morning.
About an hour ago. Came out of nowhere.
And the pain?
That just started.
Does it hurt more when you take a deep breath?
Here are his vitals.
Tachycardic, 110 BPM. Oxygen saturation, 93% on room air.
Please help me. I can't breathe.
This kind of sounds like...
Hello, Sargon?
Hey, why don't you pick up your phone?
I'm busy right now.
Oh, what are you busy with?
Radiology related activities.
Still obsessing over the plane films?
Yeah, but I'm taking a short break from that right now.
Ah, well, how long will you be busy for? I was hoping you could cover my shift tonight.
Tonight? That's in like half an hour.
Yeah, sorry, I know it's last minute. I totally forgot it was my mom's birthday party tonight.
What? How could you forget that?
How about this? I'll cover 2 shifts for you. Any shifts you want.
Uh-huh.
I'll buy you a donut too.
Make it a French cooler from Lucky's Donuts and I'll do it.
Really? Thank you so much.
No problem. Have fun tonight.
Thanks. Bye.
Hi, it's Melanie with Radiology.
Oh, Melanie. Thank goodness it's you. It's Clara. I'm on internal medicine now.
Oh, hey, how's it going? What can I do for you?
I put in an order for a stat CT chest, but I'm not sure if I did it right.
Okay, and what's the patient's name?
Last name Liu?
Got it. And what exactly are you looking for?
It might be worsening pneumonia, but also we're really worried about a pulmonary embolism.
Okay. You need a CT pulmonary angiogram then, not just a CT chest with contrast.
Oh, sorry about that. I didn't realize they were different.
Yeah, CT chest with contrast is more for assessing masses, pleural effusions, and abscesses, but we wouldn't see the pulmonary arteries very well.
Got it. I'll put in a new requisition right now.
Don't worry. I can change it on my side and let the CT tech know. As long as the history we're given is good, we can usually protocol the right scan on our side. So try to write a bit more than just shortness of breath next time. We normally wouldn't even use contrast to screen for that.
Right. That makes sense. I'll remember that for next time.
Speaking of which, someone just ordered a CT head with a history of neuro. I'll have to give them a call to figure that one out. Anyways, I'll change your order on my side and get the scan going.
Mr. Liu, just wanted to give you an update. We've ordered a CT scan to get a better look at your lungs.
What's happening to me, Doc?
Well, we're not sure yet. It might be your pneumonia getting worse, so we're going to start you back on IV antibiotics. But, given how quickly things happened, we're more worried about a blood clot forming in your lungs, called a pulmonary embolism. That's what the scan is looking for.
A blood clot? Why would I have a blood clot?
Well, infection, like pneumonia, can increase the chances of forming a blood clot. And being bedbound also increases those chances even more.
I've been trying to get up with the physiotherapist, but I've just been so weak and short of breath.
Don't be so hard on yourself. You had a pretty severe pneumonia. Well, I'll let you know when we get the scan results, and we'll take it from there.
All right, thanks for the update. Oh, can you close the curtains on your way out? I gotta use the bathroom again.
Oh, just one more thing. You're still on blood thinners, right?
Yep, and with the bruises to prove it.
Well, that should help prevent blood clots. And you said you don't smoke, right?
Definitely not.
Any previous blood clots in your lungs or legs?
Not that I'm aware of.
Any history of cancer?
Not me, but almost everyone in my family has had cancer.
Everyone?
Yeah. My mother had breast cancer, my aunt had breast cancer, and my sister had a mastectomy to prevent breast cancer.
That sounds genetic.
It is. They all tested positive for the BRCA2 gene. I didn't want to find out.
Oh.
I don't have breast cancer, do I?
That would still be pretty unlikely, even if you were BRCA2 positive. No lumps or bumps on your chest or armpits?
Not that I'm aware of, no.
All right then. I'll let you know when the scans come back.
So there's a large burden of clot in his pulmonary arteries. You see how the vessel was filled with contrast here, and then now it's blocked? We can tell it's acute because the clot is in the middle of the vessel. That's why we call it a central filling defect. And over here is where we can see right heart dysfunction. Do you know how we can tell?
Because it doesn't look like the others?
It's because the septum between the left and the right ventricles is flattened due to elevated right ventricular pressure. Normally, the septum bows into the right ventricle.
Okay, no wonder his troponin is high.
Cool, right?
Yeah, it's amazing how much you can see in a single scan.
That's radiology for you.
Oh, yeah, you didn't happen to see any breast masses, did you?
I don't think so. Why?
Well, he has a family history of BRCA2 breast cancer, so I wanted to rule that out as a secondary cause of his pulmonary embolism.
Nothing obvious on CT, but he'd need a mammogram if you're really worried.
All right, then. Maybe I'll ask my staff. Thanks for your help.
Yeah, no problem. Hold on. You said BRCA2, right?
Yeah.
Was there a provoking factor for the pulmonary embolism?
Well, we figured it was his pneumonia causing inflammation and putting him in a hypercoagulable state.
Is he on DVT prophylaxis?
Yeah, enoxaparin.
Yet he's still clotted. Hey, can you do a digital rectal exam?
What? All right, Mr. Liu, are you ready?
Can't say I expected to have my butt checked for breathing problems, but you do what you gotta do.
All right, it's gonna feel cold and wet here. Bear down on 3 and relax. 1, 2, 3.
So, you really think he could have prostate cancer?
It's quite probable. He has an ivory vertebra at L2. Sclerotic lesions like these are highly suspicious for metastases from the prostate. And the fact that he might even be BRCA2 positive makes me even more worried about prostate cancer.
Most people don't realize that BRCA2 can cause prostate cancer, not just breast cancer. So good on you.
That would explain his urinary symptoms as well. All right, thank you so much for your help.
No problem. But it's thanks to Clara for getting that great history.
So, what'd you think?
I felt a hard lump on the right.
You're certain?
Yes.
Okay, let's call urology for a consult.
On it.
And Clara? Strong work.
Melanie!
Clara! Hey, great work on call last night. How's the patient doing?
As well as he could be. Urology says he'll need a few more scans and a biopsy. You know, I'm starting to understand the appeal of radiology. I mean, you get to make all these unexpected diagnoses.
Yeah, it's super satisfying. Satisfying? That must be it. Satisfaction of search.
Wait, what?
It's a tendency to miss the second abnormality once you've seen the first. Clara, thank you so much. It's the first one. In the right humerus, there's a partially imaged sclerotic lesion with aggressive surrounding periosteal reaction. If this patient died at age 15, this is an osteosarcoma of the humerus, isn't it? This wasn't about the appearance of the pulmonary nodules at all. You tricked me with satisfaction of search.
You tricked yourself. Don't take it too hard. In radiology, we make hundreds of decisions every day, and sometimes we make mistakes. The important thing is to learn from them, and then to teach others to not make the same mistake. Welcome to radiology. I'm delighted that you've chosen this career path.
And so this patient received androgen deprivation therapy and external beam radiation therapy to his isolated met after surgery. And today, he's still alive and well. All thanks to an incidental finding on a CTPA. And that's about it. Thank you everyone for joining me for Donative Truth rounds today. Any questions? All right, well, I guess I'll see you all next week. Thanks everyone.
Ooh, I'm taking these.
Hey, I want some too.
Okay, fine.
I know, right?
Clara,
Oh, hey, Melanie.
open it. It's your turn. Welcome to radiology.
Let the shadows pull you near. There's a world beyond.
Oh, Dr. Culham, sorry, I'm towering over me. I'm sorry.
Donative Truth? For you?
Sorry. Thanks.
No problem. I'm studying joint pain next. See you around.
Bye. I took the donut really awkwardly.
All right, Mr. Liu, are you ready?
Mr. Liu, are you ready?
Oh,
Also, you're not gonna talk to the butthole, right? You're gonna
no.
look up.
1, 2, 3.
All right, now. Hey, can you do a digital rectal exam? Sorry. Let me try that one time. After all, we need to figure out what's causing the abnormalities we see, and whether it's like the donut gives you the images, but the good differential gives the meaning. Sorry.
You look so sick.
So sick.
It's the bounce that's bothering me. It's no longer dramatic.
Yeah.
Woo, we
Best
died.
makeup artist.
Woo! Best actor.
One you really need. Together we'll succeed. In the dark you'll shine.